Good morning from Space City. I know it's afternoon for you, and happy World Stroke Day. It is my absolute privilege to interview Dr. Keith Muir, who is a clinical director for stroke and the Synapse Chair of Clinical Imaging at the University of Glasgow, Queen Elizabeth University Hospital. And Dr. Muir, you've played a central role in several multi-center randomized controlled trials that have changed the landscape of stroke in the last few years, including the Wake-Up trial, the ATTEST, the ongoing ATTEST-2, TEMPO, and PISES, which are some of the ones that I was hoping to speak to you about. Before we begin, can you just summarize, what your past and current research interests and pursuits are?
How far back do you want me to go? It's kind of archaeology at this stage. Yeah, I mean, I started in stroke research in the days when thrombolysis was still a very new investigational approach. So my first research experiences in stroke included recruiting patients to trials of streptokinase and subsequently of TPA, as we know, and all of the early neuroprotection trials that were run in the 1990s. And I've ridden that particular wave ever since. I think the huge moves forward have come obviously from the thrombolysis trials. I think I've had a small contribution to make to a number of the key trials in this field over the years. I think currently we're investigating tenecteplase, and that's clearly been our focus over recent years. And I think if we're going to see significant moves forward with the thrombolytic drug therapies, I think tenecteplase looks like the drug most likely to be introduced into clinical practice. I think the successfully prosecuting the PEACE trial, which was thrombectomy as investigated in the UK in a multi-center trial, was a very valuable experience, although we were somewhat unfortunate in terms of timing to be coming in just at the later part of the curve for thrombectomy, but nonetheless hugely beneficial to be part of that. And it's been great privilege to be part of the collaboration since. And along the way, we've picked up some interesting early stage studies as well, including such things as the PISES trials with stem cell implantation and various novel approaches to potentially protecting the brain, both during and in the absence of reperfusion, which I think remains an interesting topic which we haven't fully exploited while we've been too dazzled by all of the gadgetry that we've now got to play with in the stroke field.
I absolutely agree. I feel like, neuroprotection and neurorehabilitation, your work on stem cells, I think that's really the way forward, the work that we need to be concentrating on, in the recent future. I am still dazzled, so we'll stick to tenecteplase for today. And earlier at the Congress, almost a few minutes ago, you spoke about the future of tenecteplase. And at this very moment, there is an ongoing debate between Drs. Jeffrey Saver from UCLA and Drs. Bruce Campbell from the University of Melbourne. And they're talking about is it time for TNK to replace TPA? What are your thoughts on that, and how would you answer that question?
I'm very clearly in favor of saying not yet. While respecting Jeff and Bruce and others who feel that we already have sufficient evidence, I think we are still short of evidence to make that transition. I think we all recognize that it would be extremely valuable to do so. There are huge advantages in tenecteplase, and so far we have accrued a modest amount of information. A lot of it pertains to very specific scenarios. So if you're looking at the evidence base from the small phase 2 studies, there were only 3 small trials, 291 patients, 3 different doses of tenecteplase being evaluated, and the results from those do not show any significant differences in outcomes. So that we need to leave to one side. Then we have NORTEST, the big Norwegian trial, over 1,000 patients recruited, but 18% of them were stroke mimics, about 10% were TIAs, and a very low severity on average of stroke patients who were enrolled, and therefore no great surprise when NORTEST couldn't show any clear difference in outcome. But equally, I think we need to be very mindful that the safety data, when you're recruiting on average such a mild population, need to be regarded as preliminary at best. So I think we have some questions. Nortest also used the higher dose of 0.4 milligrams per kilo that hasn't been widely explored elsewhere, and I think we have insufficient data from Nortest to really generalize to any other population and or dose. So that's a concern. Then we've got the results from Extend IAT-NK parts 1 and 2, and that again we have to be cautious. These were very selected patients. They're M1 occlusion patients who have favourable perfusion imaging, and Extend IAT-NK part 1 looked only at 200 patients. I think in most other fields, the idea we would switch wholesale from one therapeutic intervention to another alternative agent on the basis of such a small trial, and only one small trial, I think is something that would be unlikely to gain traction with cardiology. And I don't think we should rush to embrace that until we have confirmatory evidence. Extend IAT-NK2 is just comparing two different doses, but again, in this very highly selected population and without any clear difference. But equally, if you only have 300 patients recruited, then you're unlikely to pick up any clear differences in safety signal, given that we have a low incidence of hemorrhage expected. So my take on it is it is not yet possible to conclude that there is an equivalent dose or a superior dose of tenecteplase. I hope that we will have the information that will give us a robust idea of what dose and its comparability, and we should have that in the next 6 to 12 months. The ACT trial in Canada, led by Bijoy Menon, is recruiting very well. It's likely to conclude its recruitment early next year. Test 2 is sitting at over 1,300 patients recruited at the moment in the UK, and again we're hopeful that we can conclude recruitment in the early part of 2022. And the TASTE trial in the Australian centres is also in a more selected population, going to give us pretty robust data. Putting all those three trials together, we should have a sample size sufficient to really draw a reasonably reliable conclusion about non-inferiority, potentially superiority, and about safety, and they're all based on the 0.25 milligram per kilo dose.
Absolutely. I think that was an excellent summary, and you answered one of the other questions I have for you. What additional information do we need? And some of the trials that are ongoing that can address those questions. What are your thoughts on the different dosages of TNK used? And you did mention, I think most trials have used the 0.25 dose, but there are some, that are looking at a higher dose. What do you think, based on your experience or your research, what is the ideal dose that would maximize the benefit, but also have an acceptable, a risk profile to it?
I think it's very difficult to say, and I think realistically we have to be very, very conscious that the doses of alteplase that we use are not based on particularly robust clinical trial evidence. The first DCAS trial used a 1.1 milligram per kilo dose of alteplase, and it didn't show clear effects unless you started to split off subgroups. The conclusion that we should use 0.9 milligrams per kilo was based on the occurrence of cerebral hemorrhages, and I think 2 participants in an ascending dose trial way back predating the NINS study. So we actually have very limited evidence on what the appropriate dose of alteplase is. It's just that we've characterized that particular dose very, very successfully in subsequent trials. So for tenecteplase, it's quite difficult to draw very reliable conclusions. Going back to the first work on tenecteplase, Clark Haley did 2 different trials in stroke. One was an ascending dose study. The second one randomized to 3 different doses, and that included the 0.1, 0.25, and 0.4 milligram per kilo doses of tenecteplase. They had an adaptive randomization design in that trial, which meant that they were assessing both early neurological improvement and safety as endpoints to try and move randomization towards a more focused dose. And they discarded the higher dose, the 0.4 milligram per kilo dose, after only 19 patients had been recruited in that treatment arm on a basis of a combination of these factors. Thereafter, the trial concluded prematurely with funding running out before they could reach a sample size sufficiently large to draw any robust conclusions. We've had a few small studies that have looked at the 0.1 milligram per kilo dose as the lower dose, so Mark Parsons' study included that as well, but again, only 25 subjects per group. And although there are apparently dose-dependent differences in reperfusion and therapeutic effects based on early neurological improvement, I think, again, exceedingly small numbers to draw any reliable conclusions. And 0.1 has also been looked at in the context of the preparatory work for the TEMPO 2 study. So the first TEMPO trial that Sheila Coates led looked at 0.1 milligrams per kilo in this population of minor stroke or TIA, where you might hypothesize that a smaller dose would have a better risk-benefit balance because these patients generally have better outcomes and a great deal more concerned about any safety issues. So I think overall we've got very limited data. We have some data that we have from Xue Huang's sub-study of the first test trial, where we looked at thrombolytic fibrinolytic pathways, which certainly showed that the 0.25 milligram per kilo dose seemed not to disrupt fibrinolysis, endogenous hemostasis, I should say, in the same way that alteplase does, which is suggestive, but still seems to have the same markers of benefit in terms of thrombolytic effect. So based on that, plus pharmacokinetics, plus cardiology-based evidence, I would be inclined to the view that 0.25 milligrams per kilo is the closest one that matches what we would expect for fibrinolytic effect of alteplase at 0.9 milligrams per kilo. Whether that's the optimal dose for all patients in all circumstances, that's a very different question, I think, yet really to be fully explored. And it may well be that smaller doses are more appropriate for some clinical scenarios and larger doses for others. That was the ethos for the extended TNK2 program, and it didn't clearly show an effect that was better for the larger dose in that population. But I think we still have some way to go to really home in on the question of dose.
Absolutely. I think that's all very fascinating, and you summarize it very well. Now, we've been talking about IV thrombolysis with TNK, and briefly earlier in the Q&A session, we touched base about intra-arterial thrombolysis with TNK. Where do you think we are? And, I briefly had time to PubMed search it, and I found one small feasibility and comparative outcomes study that was published in 2012 out of the University of Minnesota by Dr. Qureshi and Dr. Georgiadis. So what are your thoughts? I mean, I know there's a long way to go, but do you think there's a role and that is worth looking at?
I think it's worth considering. I've got a number of reservations, and they're mostly questions of practicality. So I think the point was made in the discussion session correctly, that if we are achieving 90% recanalization with devices in these larger vessel occlusions, the additive effect of any drug that you're giving to try and deal with downstream small emboli is going to be very difficult to establish. The effect size that you're likely to get in addition is actually likely to be quite small. For smaller, more distal vessel occlusions, it's a big challenge because the outcomes are not nearly so bad. And therefore your sample sizes need to be extremely large. I'm also very conscious that once people go into the cath lab, you've lost control, and anything that can be done to get that clot dealt with will happen. And it's really difficult to stop people from doing things to deal with it, which may include stents being placed, different devices being tried, multiple passes. It includes a number of technical differences that may be relevant to outcome. The question of general anesthesia versus local anesthesia, which agency you use, how you control blood pressure. And then on top of that, of course, people give all sorts of drugs. Some of them give little bits of alteplase. Some of them probably out there still use little bits of urokinase. And there are people that are definitely giving things like abciximab. And all of these things may be happening. And it's very, very difficult even to document what goes on in that environment, let alone control it. And if you start saying to people, okay, we want you to do this and only this, and you're not allowed to do anything, even if you still see there's a clot there and it hasn't dissolved, I know that it's very, very hard to restrain people when they're in that environment. So I see it as hugely practically challenging. So even if we think it's a great idea to investigate, being able to design a trial that anybody will ever fund and is likely to produce a reliable answer is an entirely different dimension that you need to really think through. My anxiety would be that you need a very large sample size and have to invest a very large amount of effort in trying to control all of the other variables in a way that we often forget.
You're absolutely right. I think with all of that variability, it may make more sense to be, like the comparator is going to be so variable, it may just be a pragmatic trial rather than a randomized control. And even then, the effect to be seen is going to be so small that, it's hard to say if you're going to see any benefit really of adding that.
We've become extremely spoiled in stroke because we've suddenly had these succession of trials over the last 5 years with really huge effect sizes, and we have fallen into the trap of thinking that you can get away with doing a 200 patient study. Some of these thrombectomy trials had fewer than 100 participants, and the idea that you can see an effect with that sort of sample, and therefore you can conclude all these trials in 2 years flat, unfortunately is not going to apply for all of these other interventions that we'd like to test. And it's made life a lot more like cardiology, where we're looking for really small incremental changes, and you're going to need 50,000 patients to show it. So the reality of this, I think, is yet to dawn on everybody in the stroke world.
Well, we'll share this interview widely, but I think that's a very astute observation, and it sounds like that's the way we're headed. Dr. Muir, I briefly, just wanted to get your insight and views on late and or wake-up strokes. And I know one of the points of the debate earlier was, should we differentiate between these two categories or triage them similarly? What are your thoughts on that?
Well, I think the points were well debated. I think there probably are some differences. On average, that people who wake up with symptoms are more like people who have probably an onset of a stroke shortly before they wake, and therefore tend to follow the trajectory that we see from the known onset time patients, where we've got a steeply declining benefit in the first 6 hours, unless you're applying the imaging selection criteria, which define the slow progressor group, whereas the late window ones, where we know the onset was a long time ago, are really the slow progressor group that's relatively uncommon, but clearly very different in terms of selection. Does it matter how you select them is perhaps the more important question, and I think that always comes back to questions of practicality. So the wake-up trial used the diffusion flare mismatch approach. It was a really neat idea. Gostamala and colleagues in Hamburg were behind that, and I had the pleasure of leading recruitment for that just in the UK. But the logistics of getting MRI scans done acutely is quite a challenge for most countries and most healthcare systems. There are some pockets of the world where this is standard care, but for most people it's not all that straightforward. So if you can't easily access MRI, or you can't access it quickly, then defaulting to your usual pathway, which would more commonly now involve CT, CTA, CTP, is going to be the one that you favour. So I think practicalities of imaging selection are likely to be the driver, much more than debating whether there's truly a difference between the wake-up population or the late window presenting population. I suspect it will boil down to saying there are small differences at the margins. I think Bruce Campbell astutely identified that the sub-study that was done for wake-up, the only study that we have that suggests that thrombolytic therapy is effective in lacunar stroke, defined by rigid imaging criteria, as opposed to clinical syndromes. And I think that's one group where you could say currently we would not identify them reliably on CT perfusion imaging. but we can identify them positively on MRI. And that's perhaps one of the subgroups that we need to keep in mind.
I think that's an excellent point, absolutely. And so I think, what you're also saying, and I think unanimously all stroke neurologists will agree that the time of onset of the stroke, or when the stroke occurs, and obviously the collateral status are the most important determinants in, how we triage and, go forward. And I noticed that one of your current grants is for WHISPER, which is an observational study of perfusion and collateral status in acute as well as late window stroke. Can you speak a little bit more about that one, please?
Yeah, I'm very happy to. I mean, it feels like the world is moving on around about you sometimes when you're doing these studies and setting them up. But when we started out with it, it was probably more relevant in the sense that we didn't have clarity about how many patients actually present in the late time window with suitable brain imaging to indicate they're eligible for reperfusion therapies. So part of the motivation was to just try and get a reliable feel for this. It is one of the failings of a lot of our trials that we don't really collect screening log information. So even we're, as a reviewer recently put it, we seem to be missing the top line of our consort chart in a lot of these studies. You would normally have an idea of how many you screened for enrollment, which is based on how many patients came in with stroke, how many were actually scanned, how many were in the time window. And actually, we seldom do that in the stroke world, and we seem to have got away with it just by saying, oh, we looked at the number that came in, which is way lower than the number of patients admitted to the stroke centre. So we don't really have a reliable, robust idea of what proportion of patients who present might be eligible for treatment. And the motivation was largely to look at that. I've also been interested in what determines why some people develop and some people do not develop collaterals. I think the idea that the collaterals are sitting there and just sort of click into action when there's an arterial occlusion, more approximately, is something that seems not to be the case based on animal data that my now retired colleague Mary McRae had led some years ago, where if you occlude the middle cerebral artery in a rat, there aren't no collaterals at all in any of them to start with, and the collaterals develop somewhat gradually over the subsequent 30 to 60 minutes. So the idea that collaterals switch on at time point 0 and gradually fade over time at a varying rate is probably not right. They switch on rather slowly in some people, but not all. And if you make your rats hyperglycemic, they never switch on. The interesting question to me is that the same scenario in humans? Is that why hyperglycemia is such a powerful predictor of poor outcome and interacts very powerfully with effectiveness of reperfusion therapies in general? So the understanding of why some people develop collaterals and others appear never to is tied up with this question of how long you have, what's your personal individual time window, and how best to image that. Imaging a penumbra is essentially imaging adequacy of collaterals. That's the reason you've got the penumbra. So they're all getting at exactly the same question. But I think we have some potential value in trying to understand why collaterals appear in some people, most people, fortunately, but why they don't appear at all in others.
I think that's a phenomenal question, and I'll look forward to what your findings are on that.
Hopefully soon.
Hopefully soon, absolutely. Dr. Muir, any words of advice or pearls of wisdom for our stroke trainees?
I collaborate with people, and I think that's the most important thing. It's interesting that we generally all converge around similar ideas. There are very few original ideas out there. Everybody thinks along the same lines. I don't know that there's any other field of medicine where we have seen such dramatic changes in such a short space of time. And I think there's enormous hope for the future in answering all these questions, all the sort of questions that were raised there. what doses of thrombolytics, which thrombolytic, when do we give it, which type of patients are we giving it to, what devices are we adding it to, how are we selecting them. To have the luxury of all of these tools and all of these questions and all of these interesting things to address is a fantastic luxury. When I started off in stroke, we had no treatments at all. It had maybe just about been accepted that aspirin might prevent second stroke, but that was about it. We had a CT scan that might be done within the first several days of hospital admission, but still a lot of people arguing that there was no point in going to hospital because there was nothing to do anyway. And we started with that as our baseline for what we were doing with stroke. So it's moved an immense distance in what is, it doesn't feel that long, although it's been about 30 years altogether now. And I think that the coming years are going to see enormous advances in interventions. We have the tools, we have the people, and we definitely have the knowledge that we can make a difference to outcomes.
I think that's amazing, and I feel like I can, share what your experience, at least in your initial early days, where I was attending the LMIC session at the World Stroke Congress yesterday, and it sounds like what we in the US, UK, and Europe were like 30 years ago. So no access, patients don't go to the hospital. So it is indeed a luxury to have access and availability to all of these devices and technology and these questions. So I appreciate you taking out the time to speak with us today. And really, that was super fun. Thank you, sir.
You're very welcome. Pleasure to speak.
Take care. Bye-bye.
Bye-bye.